clinical psychologist and has worked in the private and public sectors, providing mental health treatment and policy development for more than 20 years. He most recently worked for the California Mental Health Directors Association before moving to Harbage Consulting. He has extensive experience with mental health policy development at the county, state, and federal level. So, here's Don.
Good afternoon. You guys want to sit down, huh? It's okay. I know. You could run screaming from the room, huh? It's a test. It's all right then. You don't have to sit down. First of all, as said, Don Kingdon, I'm with Harbage Consulting, and I want to acknowledge that my brain is only as good as the brains that the people work with me. I've been very lucky to gather a behavioral health team at Harbage that includes some of the names you know, Molly Brassel, who is this half of my brain, Mike Geis, who's a good portion of my brain I've learned a lot from, and then we've also been able to add Courtney Kashiwagi to our team at Harbage, and she's had some pretty extensive experience in New York with the DISRIP. You all heard Ron Manderscheid talk about delivery system reform incentive pools, so we may have an opportunity to talk about that a little bit today. So that's the real brains behind the organization. Also, I just as an aside, has anybody seen the Intern movie now? Yeah? So I feel a little like the intern at Harbage. I'm surrounded by 30-somethings who are very energetic, and are just, I've learned a lot since I've been there. And what I'm going to try to do today is give you a perspective that I've gained about healthcare financing, a couple of words of, there are no numbers in this presentation, so you're going to see an entire financial presentation without numbers. And I think some of you may scoff and think, well, where's the numbers? But what actually I'm going to be doing is helping you understand what I've learned is that healthcare financing really is much more and drives policy much more than we like to acknowledge. And whether you know the numbers or not, it's very important to understand the policy aspects of how healthcare is financed and paid for in our country, because it has driven quite a bit of where we are. And it is the challenge that the Affordable Care Act is laying out before us. It's the challenge you heard Ron Manderscheid refer to this morning, the pay for performance, the focus on something other than fee-for-service structures we're going to be talking about. And ultimately, it's this complicated interaction between what we are paid and what we actually do for, with, or on behalf of the patients we treat. I am going to use healthcare language. I apologize a bit from the start. But you will be hearing a lot of healthcare language. Eventually, we will talk more about behavioral health. But I do think it's important that behavioral health understand that it does and does need to become a part of the healthcare structure. So some of the language I'll be using is more related to healthcare. So a couple of concepts before I dig in that I think are important to understand in the world of healthcare financing. So the two very simple structures that we all know well because we balance our checkbooks or whatever we do nowadays when we have money coming in and out is the concepts of revenue and expenditure. Sounds very simple, but in healthcare it is simply on the revenue side, it's about beneficiaries and either what happens to them, what we do to them, or what they enroll in. And so in terms of healthcare, when we're talking about healthcare today, and we're talking about money, beneficiaries at one level or another drive the revenue side, either through the procedures that we perform, as I said, or because they're enrolled in healthcare, or because we are doing something to them in billing. And then on the expenditure side, expenditures in healthcare are very simply, for the most part, divided into two categories, administrative and patient care. And the reason that's important is because in many of the capitated arrangements today, there are actually percentages that are targets for how much can be expended administratively versus how much for patient care. They call it the medical loss ratio. ACA sets for health plans some targets. In general, what those targets are is at least 80% of expenditures or more need to go to patient care, leaving the rest for administrative activities, which are probably related to claims and other things. And what we're going to be talking about today is the complicated relationship, or not so complicated relationship, when revenue and expenditures match or don't match, and who's at risk. But keep in mind, when we're talking about revenues, we're talking about beneficiaries and things that happen or happen on their behalf. And we're talking about expenditures in healthcare, we're talking about either administrative or the bulk of expenditures related to patient care. And then the other concept that we're going to be talking about is called risk sharing, but basically can be boiled down to who pays. And some examples of this, just to give us kind of an idea. So in commercial insurance, who pays or who's at risk is really shared often between three entities: the insurance plan, the employer, and increasingly the beneficiary, the covered beneficiary, as you heard today. One of the trends we see on commercial side is pushing more and more of the cost over to the beneficiary themselves through increased co-pays, increased charges, and those things for certain activity. One of the very common things we're seeing today, for example, on the health side, is if you go to an emergency room, your copay for that visit in the commercial side is much greater than if you go for a primary care or a planned outpatient. And what that is doing is introducing the concepts, which we're going to be talking about today, of incentives. How do you incentivize patients to seek beneficiaries the right care? And we see on the commercial side more and more they are using co-pays and other things for that. The other important thing about the commercial side is the folks that have a stake in it are changing. As you heard today, the federal government now has a stake in commercial coverage through the subsidies, the income subsidies that they are now providing for families that do not have adequate income to buy commercial insurance. And that's going to be important, as you'll see later. The more the federal government gets involved in things, the more government tends to play a role that can create some of the some changes in the incentives. And then we're going to be talking today mostly about federal health care programs. There, the sharing is a little clearer. So on the Medicare side, as you know, largely the share is the federal government. The beneficiary for Part A and Part B have a percentage share in the cost of their care. And then increasingly, we're seeing health plan enrollment as a player. So the health plans are absorbing some of the risk, the who pays, in the Medicare system through the DSNP programs, enrollment in Medicare managed care, and then also in changes in some of the coverages provided and some of the incentive, co-pays. What we're primarily going to be talking today, though, is about the Medicaid program, Medi-Cal in California. And there it's pretty much the federal government and state government sharing in the risk. And in behavioral health today, we see local government, the county, participating. The reason both of these things are important, just to remind us, so that when we're talking about money, we're not talking about money, we're talking about people, beneficiaries on the revenue side, and we're talking about delivery of health care and administrative cost on the other. And when we're talking about money, we're talking about sharing of risk. So the reason we're not going to be throwing out dollar amounts today is I think it's much more important to boil this down to those concepts and then try to understand the incentives associated with those concepts. Any questions about the concepts? Any challenges, concerns before we move on to what does this all mean in terms of where things are going on federal payment side? Nope. All right, so let's look at the various, again, risk partner perspectives on what's going on and why there is such an interest in payment reform today. So on the federal side, Fed's got a problem. The ACA is a solution that creates a problem from a financial perspective for the federal government as the risk entity that it is today. And basically, and some of you have heard this before, their biggest exposure right now is to increases in Medicare and Medicare expenditures at the state and national level due to the ACA. The Medicaid coverage expansion, 100% coverage for the newly enrolled. California alone in the last, we're working with a group of counties. We've seen a 40% or more increase in enrollment in Medicaid. And of that 40% increase, we estimate that well more than half is for the expansion population. And test who's at risk. Feds, 100% risk, at least for the next few years. On the Medicare side, they have an aging demographic. You heard Ron say they are very interested in performance-based payments. California has a coordinated care initiative where they're taking Medicaid and Medi-Cal dollars, blending them into a capitated arrangement. CMS was very interested in California entering into this CCI agreement and very interested in sustaining it because CMS would like to see an increase in Medicare beneficiary enrollment in capitated health plans. And the reason for that is the next fee-for-service payments for units of care are costly, administratively inefficient, they incentivize volume rather than risk-adjusted care, and they do not lead from the federal perspective to the right care being delivered by the right provider at the right time and at the right place. And that is just a perspective that, from the federal perspective, is becoming really, their focus is to shift as much as they can of the fee and payment structure from paying for things that happen, whether they happen to a lot of people or just a few people, to risk arrangements. And we'll be talking about what those risk arrangements are more as we go through. And then the third thing that's going on is the CMS has a lot of information today about what is happening to people on an encounter-by-encounter basis. And the reason for this is the part of HIPAA that many of us didn't pay as much attention to in the beginning because we were so concerned about the privacy aspects. But today you're all paying attention to, and today particularly you're paying attention to because it's the anniversary of what's happening today, October 1st. Boom. There it is. And why is ICD10 important to the feds? Huh? It's chock full of coded information and specificity. Thank you very much. An ICD-10 code can go all the way out to what level of functioning. I didn't realize this one, but what level of risk and impairment was associated with a recent suicide attempt. There's coding in that structure in ICD-10 to do that. All of that, the reason that's important is today every single provider of federal health care has an MPI number. Every patient has a unique identifier. Everything that they think the patient has is coded, and everything they do to the patient is coded uniquely. And all of that information is now available to the federal government to move from payment for doing things to payment for performance. And it's a huge infrastructure. It's now available to the federal government. We're starting to see a little bit of its use here in California. You may have seen some recent report cards related to hospital-based infection. Those kinds of things are the kinds of things the federal government has now related to federal health care payments that they didn't have before. And it does lead to the potential to start paying people for doing the right thing as opposed to just doing some things. Yes?
On your second point fee-for-service.
Yes.
What we heard from Karen this morning or this afternoon, that we probably there's no talk about the carve-out. Do you think that we could stay carve-out but go to a different kind of method? Is that what you're saying?
Great question, and we're going to answer it. The short answer is yes.
Okay.
Yes. And really, just to preview that, and many of you heard this, there are two ways to pay for health care in a waiver, risk and non-risk. We're currently a non-risk payment structure. Most managed care is designed to eventually become at-risk, and we'll talk a little bit about what at-risk payments are and why they're important today. I just want to emphasize again, though, that the level of information that is now uniformly being collected so that you can track results of patient care is really what drives pay-for-performance initiatives forward now. Without that information, it's a guess, or you're relying on the provider to collect the information, or you're hoping for a good outcome, but you don't have the capacity to actually measure, track, and feed that information back, most importantly, the patient themselves, but the provider. That capacity now exists because of the significant changes we've seen in healthcare coding and things. Medicaid information technology architecture incentives are the state getting paid 90% federal money to take this information that we just talked about and use it for just what we're going to be talking about, which is to improve care, to focus on improved care, to provide information back to both providers and the beneficiary about the results of their care. All right, we're going to move now a little bit into things that I know are more important to us because we're behavioral health providers, and that's what are the perspectives around our program specifically. So what's one probably the most important things that California has done, and it is a little bit of the reason why you heard some discussion about DSRIP this morning, delivery system reform incentive programs. New York is engaged in a DSRIP. The primary focus of the New York DSRIP is to prepare itself for a capitated health plan enrollment system. But what it didn't have and doesn't have is a network of providers associated with hospitals that are ready to absorb those kinds of risks. So a lot of the New York initiative is to prepare for that. California is unique is that California has already done it. 80% or more of Medi-Cal beneficiaries in California today are already enrolled in capitated health plans, and you all know that well because you all have MOUs with those capitated health plans. This is a significant, I can't tell you how significant and important that change is, and California is out ahead of just about every other state in the country in being able to move that quickly from a fee-for-service structure to a capitated health plan enrollment structure. And just to give you a sense of how big that is, what that means is the state doesn't have to maintain a massive fee-for-service payment structure for every single healthcare encounter that happens in California any longer. That was a huge undertaking, very difficult for the state to do. When you capitate and you hand responsibility to health plans, they now are responsible for paying providers, no longer you. So just that alone means that you can take what you've invested in sustaining that fee-for-service structure and put it into other things because you've shifted that responsibility from the state to enroll Medi-Cal providers for health to the health plans who are now responsible for that. The other thing that we talked about a little bit, California is very committed to, and even though at times politically folks I think still question it, is this Cal-Medi-Connect partnership with CMS. It is very important, as you heard, from CMS perspective, to get as many Medicare enrollees enrolled in managed care for the very same reasons that the state has an interest in that. And that is because it's administratively more efficient and with the information available can lead to improved care as opposed to just paying for a volume of care. Sorry about that. And then the other thing that California has done that's unique, and I think you heard Ron talk about the carve-out is going to go away. Probably one of the reasons that the carve-out isn't going to go away as fast as he's predicting is this third one, is that the state has very smartly realigned the responsibility for payment for especially mental health and now the drug and alcohol treatment program, both waiver and non-waiver, to the counties. So what that means every year is Department of Healthcare Services doesn't have to ask for an appropriation for those programs. They can rely on the fact that those programs are funded by dedicated tax revenues, both sales tax and income tax, and it frees the state up from that obligation to meet those requirements. And so I think for the carve-out to go away and the state to absorb back all of that cost and activity would be very difficult. Doesn't mean, though, that the federal government won't continue to put pressure on the state to move to some other kind of payment structure because the feds, remember, are at risk. In California, the counties are at risk for the match. So, yes?
Would that ever legally be able to happen on a
You know, it's a good question. There was a time when it was structured so the county could fail or give it back. The counties could still fail and the state take it back. And who they would give it to, is still really a question. How much would they take back? What would they take back? Who would they find that would deliver those services? How would they offset the money and bring the money back? Are all open questions. Go ahead.
Partially also just meant in terms of the carved out funds, could they ever be carved in on county by county basis?
You know, from my perspective, I don't think you could do that on a county-by-county basis. We'll talk, though, about the various mechanisms, how local government participates. There is a mechanism that the county can give the money back to the state, and we'll talk a little bit more about that in a bit. And then, as I said already, what the state is being able to do is be much more efficient in how it uses its information technology money. One of the projects that the state is working on now under MITE is modernization of the MEDS eligibility determination system. And the reason for that is what the state does need to know very clearly today is who is and who isn't eligible, who has shares of cost, because those beneficiaries now, from their perspective, are capitated to the health plan. So they need to know on a month-to-month basis how many enrolled beneficiaries there are. They're making capitated payments based on that to the feds. So there is a real interest in making sure the eligibility system is accurate. And talk about county perspectives. Just want to remind you again, I don't work for CBHDA, work for Harbage, but Harbage does have a contract with CBHDA, but I think these are fairly generic county perspectives that we can all agree on. Because of the structure of how the counties are reimbursed, it's very important for them to get as much appropriate federal reimbursement as they can, because this program is realigned and they are incurring what's called the certified public expenditure. In other words, they have all the cash risk. The county pays for a service 100% and then claims that service and hopes to recover on a timely basis the federal share, depending on what that federal share is. So the counties and not the state, in this case, have all of the cash risk associated with the realigned programs. I think the other interest is efficient and, as we said, accurate federal payments, and then also appropriate and clear administrative quality and results expectations. And many of you are aware, recently CMS came back to the state and added some special terms and conditions to the mental health waiver. And specifically, those special terms and conditions are focused on this area. They would like the mental health plans to look a little bit more like the health plans in how they are benchmarked, how they are dashboarded, and how they are reporting quality and other kinds of results. You may or may not know, but all health plans are dashboarded actually. Dashboarded meaning they are compared to each other on a number of variables, beneficiary satisfaction, access, timeliness, and various other variables, and that is all publicly reported. And if you go into these dashboards, you can compare Kaiser to Blue Shield to, and see how they perform on those areas. And then lastly, as a result of 2011 realignment, there was a state constitutional provision passed, and basically what it says is the state can't add additional responsibilities to the counties without reimbursing them from some source. And this is really to protect what is a state and county relationship, which basically has to do with whether or not the state can require the county to do something without asking them to pay, and or without paying them, I'm sorry. And what that's called is a mandate, a state mandate. Counties are eligible to be reimbursed if the state asks them to do something, either a state function or a federal function. In this case, those mandates claims were waived. In other words, the county couldn't submit a mandate claim, and in its place for specialty mental health and for the drug Medi-Cal program, there was here's a line. If you ask us to do any more than what we were doing up until this line, then you're going to have to pay us to perform those functions. And yes?
Don, I was going to ask you also, how does the ACA's, I guess, formula for taking down the disproportionate share of hospital payments to 2017 that it will start to diminish? And what about those counties that have a lot of undocumented? They're still sort of on the hook.
No, it's a very good point. So what she's referring to is because of the ACA and in the increase in coverage, disproportionate share payments to public hospitals are being reduced because theoretically there are less people who are uncovered. So there is a gradual reduction in disproportionate shares payments to public hospitals that's being made, or hospitals in general, over time. What to do about the undocumented, I think, is an important issue. As you know, in California, we did decide to insure children, I think next year. And what that means, though, is when you go back to risk sharing, the feds have no risk in that. That's going to be all state funds because there is no federal reimbursement. So that's one of these times where we have created what are often called state-only coverages because there will not be federal financial participation associated with that. So it will be a general fund obligation.
Do you think there is any movement at the state level to try to deal with this?
You know,
For California?
I can only speak now. I've left the advocacy field because politics are very frustrating, as you know. Well, I think a lot of what it depends on is how successful the state is in convincing CMS to help California with the new 1115, because going back to the sharing ratios, the more federal funds there are for other programs, the more that can free up state general fund to do other things. To the extent they're not successful and the feds dig their heels in because of the first slide, which is we've had it, we don't intend to participate more than we already are. That will create some problems for the state to do the things they may want to do if they cannot draw down those additional federal funds. So we'll see. Yes?
Donald, we're coming up on 2 years after ACA got implemented.
Yep.
At least speaking from Northern County, we've got healthcare plans that have been paid a tremendous amount of money to serve the mild to moderates, yet continue to not meet that obligation. We get audited, we get all sorts of things happen to us, but I'm not hearing on the other side there's any kind of auditing and perhaps recoupment of funding, because when we meet with managed care plans, we're told, oh, we're providing our guidelines, or we meet, we're seeing people within 10 days, we're saying, call any of the providers on your list. Some of them are actually deceased. They don't even provide services. Is there some kind of auditing coming soon to have some parity? Because we're under the microscope.
You are. So I'm going to answer your question a little bit now, but by the end, hopefully I will have completely answered it. And so what I'm going to answer it first is from the health plan perspective, their capitation rates were actually not adjusted to address the mild and moderate, and they were not adjusted to provide the ABA services that they recently were required to do for those on autism spectrum disorder. And that's not to say, though, that when capitation occurs, if it occurs when you're seeing a huge increase in beneficiaries, that you don't find yourself in a strong cash position for a period of time. And we're going to talk a little bit about that. So what capitation is, and we're going all the way to the end, but I'll just do it. What capitation is, you pay per member per month. You don't pay for procedures. And the plan gets that cash infusion. And to the extent that you're in a growth mode in terms of number of beneficiaries being enrolled, you have an infusion of cash. Now remember, they can't spend any more. They have to spend at least 80 to 85% of that on patient care. So they have to meet that MLR, and that is one of the areas that they are held to, that they are expending at least 80 to 85% of their funds on patient care. Their method for accountability, though, is much more about reporting on the results, because in not all of the state do we have a lack of freedom of choice. So in other words, theoretically, in many of our counties, as you know, not all, but many, they have a choice. The beneficiary has a choice in health plan. And then the role of the state is, in oversight, is to report the results and let beneficiaries choose. The reason, and we'll talk about this more, counties are held under a higher level of scrutiny is the beneficiary has lost that choice. They don't have a choice. They're stuck. And when you are in that environment and the beneficiary has lost choice, you'll see a greatly escalated level of oversight. And then when you add to that a fee-for-service payment structure where you're getting paid to do things, but nobody knows for sure if you're being paid, you're just being paid to do things. You're being paid for volume of care. The way the federal government takes care of that is they come in behind and take as much back as they can after the fact. That's how they control their risk, and and they've created a real narrative around that, fraud and abuse. But that is, as you'll see as we talk about later, one of the downsides of fee-for-service payment structures for plans that are reliant on fee-for-service payment is the real incentive, because the feds are going to get their money back one way or the other. They're either going to get it up front by negotiating a capitated rate and containing their risk that way, or they're going to keep paying and then come in behind and find a way to at least recover some portion of the payments they've made. And I'm sure you've all heard stories that there are subcontracted providers who are actually incentivized to certain recovery levels.
But just to clarify what you said earlier, so the two managed care plans were not given additional money to provide mental health care. It's wrapped up into their health care rate.
From the managed care provider perspective, their rates have not been adjusted, and as a matter of fact, are actually too low. One of the populations that has created a real problem for them that they didn't get an adjustment for are SPDs, seniors and persons with disabilities. There was a massive enrollment of seniors and persons with disabilities into the health plans about 2 years ago, and there was no risk-adjusted capitation made for that population. So again, I'm just, from their perspective, their capitated rates don't reflect that activity. From other perspectives, though, they have done fairly well on a cash basis because of the increase in enrollment. They just have more people, so they've got a lot more money, cash.
By shifting the payment method, does it allow greater flexibility, or are those capitated rates still set like the fee-for-service?
So health plans now actually set the provider rates, but providers will tell you they haven't set them very high. Matter of fact, I think most health plans are 80% of Medicare. So the health plans yet are not adjusting their rates up for provider networks. That will change over time to the extent they can't get an adequate provider network. The other trend we're seeing is that they are subcapitating or risk-adjust paying provider groups. So in other words, they get a group of physicians come together and say, we don't want to be paid on fee-for-service basis anymore. It's not working for us. You don't pay us enough. We will go to a risk-adjusted payment structure where you pay us in some other way as a physician group. And we're seeing just the beginnings of that. Yes?
Well, I think as with the county, I don't think we need to lump all the health plans together because, I'm from Partnership Health Plan. We work with 14 counties, and we have since the
I'm glad you outed yourself.
Yeah, from the beginning of the year, there's a lot of, we feel much the same way about counties. Why can't we understand what they're doing with their money and why they aren't serving who we think we are not supposed to serve? So, a lot of discussion needs to go back and forth, but for example, a partnership in our 14 counties, we've been paying Medicare rates since the beginning of the year. And it's because we're very well managed and we have a administrative cost that is far less than what you just described and put far more into our patient services. And so it really depends, I think, on which health plans we're talking about. And when we look at our counties, we see that some counties are doing very well in handling their SMI population, and some just do not have the money or the capacity to handle. And then it's you know, that's where the bifurcation is really getting into trouble.
And
We
I,
need to talk to each other about it.
and I think that the point in that is, from the beneficiary perspective, it does no good to see these as competitive systems or systems. It doesn't benefit the beneficiary, because the beneficiary, and this is the wrong words, is stuck with those enrollment options. They're less stuck on the health side, actually, than they are on the mental health side, because they do have a little bit of choice and they can revert to fee-for-service. So I think the point is well taken, and hopefully by the end, what we'll all agree on is probably to make something work that's more collaborative, we have to come closer together as to how we're actually structured and paid. Because currently there is a big difference between how the health plans are paid from an at-risk perspective and the incentives that creates for them, and how the counties are paid on a fee-for-service basis. So hopefully when we're at the point where we're having some conversation, we could come up with some good ideas as to why mental health plans may want to look on a payment side a little bit more like the health plans themselves. And then lastly, just want to emphasize that Medicaid requires, as we said, it's a risk sharing between the state and federal government. In California, local government does play a role in the behavioral health system, and there are two ways. This answers, I hope, the question there earlier. There's two ways that local government can participate in federal health care programs. One is through what's called certified public expenditure, and basically that is you just pay 100% and get whatever percent back from the federal government the feds are paying, and that's based on a percentage, what's called the FMAP percentage. Another way, though, is for the county or the local government entity to transfer their tax funds up to the state, and then the state use those funds to draw down federal funds and give a prearranged payment back to the local government. That's been used a bit on the public hospital side. But those are the two ways that local tax funds can be used. In California, for behavioral health today, under the waiver for drug Medi-Cal in the current drug Medi-Cal system and for specialty mental health, the structure is a certified public expenditure. All right, so what can we do about this? So first of all, if you buy the premise that fee-for-service is not the way to go, then the question is what is a better way to go? So we're going to talk a little bit about what payment alternatives federal government currently offers, starting with kind of the basic and working our way forward. So CMS can approve alternatives to the required state plan coverage and rates through waivers. So basically, federal health care is driven by an agreement between the state and federal government that's called a state plan. And the state plan specifies who can deliver the service, what the services are, who's covered, and also a rate structure that the federal government approves. And in this case, usually that rate structure, but not always, is a fee-for-service rate structure. If, though, the state decides to apply for and submit a waiver, the state and federal government can agree to an alternative rate structure. And that's actually what's happened in the 1115 waiver. I'm looking at my other Don. That's my, Don's here from DHCS. So the state was able to convince CMS under the 1115 drug Medi-Cal program, convince them to allow the state to enter into an alternative payment structure. And as you all know, counties will be submitting their proposed rates under that structure, and no longer in waiver counties will drug Medi-Cal be reimbursed based on just the state plan rates, those rates that are specified and approved by CMS in the state plan. And then CMS can also waive specific provisions of the Federal Social Security Act, freedom of choice, any qualified provider. There are a few others. Freedom of choice is a big deal to the feds, because what you're literally saying is you're taking away the beneficiary's ability to choose their provider. I don't know how many of you have commercial insurance in here. I don't know how many of you have elected to go with a closed network, provider network like Kaiser. Many folks say, I'm not going to do that. I want to be able to choose my provider. And when you think about it, that's a big deal, to have that taken away from you as a Medicaid beneficiary. And that's exactly what has happened in the case of the specialty mental health program. The beneficiary has lost freedom of choice. The obligations that creates and the things that it creates in terms of what counties really should be thinking about and doing, I think are monumental. In healthcare, except for in certain counties, the feds have not taken that freedom of choice away, but have left that freedom of choice intact, unless certain parts of the state or certain health plans have been able to convince the federal government that they can do a good job. And we do have that partnership as an example of one of those plans that has been able to accomplish that in parts of our rural Northern California. And then in almost all, if not all cases, once freedom of choice and any qualified provider requirements, and that's called closed network, are approved, the federal government requires that a series of managed care requirements related to access, beneficiary protection, reimbursement, and quality improvement are added back. So with freedom of choice removed, the feds are then very interested in making sure that health plans, or mental health plans in this case, meet certain access, beneficiary protection, and other requirements. Beneficiaries have the right to appeal. Plans can show adequate networks and those things. Yes?
Sorry, what does SSA stand for again?
Social Security Act.
Oh, thank you. Goes to-
It's the big rules. It says the big rules, and then there's CFR that interprets the big rules. But the Social Security Act, basically the core of the Social Security Act for health care programs is you get to choose your provider, and any provider that's qualified can deliver services. That's kind of the core of health care. It's when those things are waived, and we're seeing them waived more and more. One of the problems with that is it doesn't always lead to an adequate network, and managed care requirements don't apply, so you can have significant parts of a state that aren't covered because you haven't waived freedom of choice and you're not limiting provider enrollment, you're just not paying enough. And so that's why I think we're seeing more and more of this, the managed care approaches in states, because it actually is creating some obligations for access. Just quickly, states are reimbursed by CMS for Medicaid on an interim basis, just like you. States' claim for federal funds are subject to validation, reconciliation, and cost settlement. The key element here is that when it comes to certified public expenditure, the payments that are paid during the year for specific activities are considered interim payments. Actual, final, and real payment from the federal perspective happens after reconciliation, cost allocation, and settlement, which is often 1 to 2 to 5 years after the interim payments have been made. And essentially that just means that the government entity that certified the public expenditure has to show that they've appropriately allocated their costs to the federal health care program, and that they have all of the costs necessary to support the rates they received during the year. This is the important issue that we're going to kind of lead into, like, what can we do instead? So states may also enter into non-risk or risk-based agreements with CMS for federal reimbursement, fee-for-service, which we are currently structured under for both the drug Medi-Cal waiver, the demonstration, and for the 1915B, is a non-risk payment structure. Just means you get paid for each encounter. You bill the encounter, the federal government gives you your money. And then after the fact, your risk starts an audit, both on the financial side, but it's considered a non-risk payment structure. Our waiver, the 1915B or the 1115 for that matter, could be structured under a risk payment structure, and an example of that is capitation, and we'll talk a little bit more about capitation. Yes, absolutely.
I'm just trying to understand how this thing might work, like 2 or 3 steps ahead. So right now we get paid as cost reimbursement. We submitted cost
You get
report.
paid for volume.
Well, at the end of the year, we have to submit a cost reimbursement.
You do.
We have to have the cost to
Support the volume.
support the volume. So we wouldn't have to do that if we.
There's the answer. No, I'm ignoring it. Go ahead.
we wouldn't have to do that because we're getting paid by person. Let's say that you get 100 people, you get this much money, and that's it. Or you still have to do a cost settlement at the end, or how?
So we'll get into it. So a non-risk payment structure theoretically does fix risk. So say, for example, capitation. You and the federal government or state government agree on a capitated amount, or they just tell you what it is because they and the federal government have agreed, and then you are paid on a per member per month basis. And what you have to meet are the administrative to patient care ratios and then all of the quality and other incentives. And we have somebody here that's living in that environment. Anything you want to add? Okay.
So the cost wouldn't matter at the end? I mean, you could technically make money?
Well, so again, cost matters when volume is the driver, because the federal government's interest is, okay, I've paid you for all this activity. You've done a bunch of stuff to some people, and you tell me that this is what it was worth and what it costs. I'm going to come back and make sure that's actually what it did cost. The federal government's interest in a capitated arrangement shifts to, are the people getting better?
Okay.
And your interest theoretically shifts the same, because once you're capitated, your interest becomes in keeping people as healthy as possible, addressing conditions as early as possible. There's really no incentive in fee-for-service to catch a condition early. As a matter of fact, in some perverse environments, wait till the condition gets bad enough so that you can do procedures that are more costly. There have been some hospitals that have been caught for doing that, or misdiagnosing conditions because you can draw down more funds for performing certain activities in fee-for-service. When you shift to other payment arrangements, the incentives change, and that is the point, as you'll see in the end, that the ACA is trying to put out there, that payment incentives can drive what a provider pays attention to, and what a provider pays attention to needs to be the health and, yeah.
Don?
Yes, please.
You didn't quite accurately describe how we get paid.
Thank
We
you.
don't get paid for volume. We get paid for our costs, and then we get penalized if we don't provide enough volume. That's what the CMA or the SMA, that's.
Very, very well put.
Accurately.
Even more perverse. Thank you, Ren. Yes.
So for capitation, what mechanism does the government have to lower the rate beyond a certain level? I guess if I'm saying, they say, okay, it's $100 per person per month to do this, and we have incentive to do that efficiently to meet the person's care with $100. But if we do it extra efficiently and do it for $80 and provide the same level of care, then what's our incentive to do that? And how do they know to, because they eventually would like to lower the capitated rate per person if we're being innovative, but we don't really have an incentive to do that, right?
It is a very important issue right now for the health plans, and my understanding, and I don't want to mischaracterize it, so correct me if I'm wrong, that what the health plans are saying is right now our rates are driven by events that are more costly. To get our rates up, we need costly events. We're willing and would like to be able to reinvest in things that are less costly or that might be more supportive, but because of the MLR, we can't count those as medical costs, or because of just the structure of how rates are constructed today, we actually have some incentives that we would like to see change, the health plans, because we would like actually to have performance incentives associated with keeping people well as opposed to hospitalizing. So it's a very important issue right now. Even in capitation, you've got problems
You raise
with
an
incentives.
excellent point. Those of us who've been around long enough remember negotiated rates, and we remember them fondly, but the part we don't remember is once we would negotiate a rate of $100 and we could do it for $80, the next year they wanted to make the rate $90, they wanted to take some of that money. We forget that part of it, that they wanted to take some of the money back that we're able to save. So, be careful, let's not, be careful what you wish for. I mean, people always are ready to get rid of cost reimbursement, but, the devil's in the details.
It is.
Some-
It is. Let's move along. Let me see if there's anything here that's really important before we get to actually talking about some of those things. Nope. I think we're good. Provider requirements. I think we all know what these are, at least today. So let's talk about delivery system perspectives, because this is just where I think we can start the conversation, not with money, but with what the goal is, and then figure out the best financial structure to accomplish the goal. So managing care and risk requires monitoring and addressing prevalence, penetration, utilization, and outcomes, including cost. Do we all buy that? So prevalence. If a certain number of people have something and they're in the population, and this is what Ron was talking today about population-based healthcare, are those the ones getting in? And then once they get in, are they receiving the appropriate care? And if in receiving the appropriate care, do we see the outcomes that we would like to see, including cost? I would challenge anyone in the room to tell me how a fee-for-service structure will cause you to pay attention to all four of these, including the population-based variable. And I'll give you a minute, but if I can get paid the same for seeing 3 people that don't have it as I would for 10 that do, why wouldn't I just wait and see who shows up? Because I'm going to get paid for doing some things. So, yes. So I think what the ACA is, what folks are kind of trying to say, that, you know, whether the carve-out's dead or not, is that if we want to move our focus from procedure-based healthcare to population-based healthcare, then we need a payment structure that incentivizes us to pay attention to all four of these variables simultaneously for the population for which we're responsible.
Because on a micro level, we can already think about that with the expansion of Medicaid and the growing numbers in our clinics. We are trying to get our culture of providers and therapists and clinicians to change their way of thinking, because we have these access requirements on the front end that we need to meet as an administration. But you can see how organizationally the culture to get a therapist to agree that seeing 2 patients in an hour and 10 minutes versus 1 that I can just linger with, right, is harder for them to change that culture and that idea, because that feels like more work, even though it's not an hour the more work, it feels like more work. So on that micro level, we can already see how that's hard to do.
Absolutely.
Try to change that culture.
Absolutely.
And even to follow up on that, like just trying to, let's get them better and get rid of them, so we have turnover is just very difficult to get into the clinician's mind. It's like, you know, somebody cannot be with you for 2 years, 3 years, and you haven't done really too much with them, you know, just get them in and out. It's been really difficult.
Because it's more fun to work with those who are healthier and stronger than the most
Yeah,
disabled.
because they need it.
So, so far nobody's convinced me that you can accomplish all four with fee-for-service.
No, it's the opposite.
All right.
You can
So,
accomplish it with EQRO. They'll make you accomplish it.
the EQRO's a part of the loss of freedom of choice, but anyway. All right, so let's go to the next. So what are some of the performance goals that we'd want to establish related to this? So on the prevalence and penetration side, what we want to do is minimize false positives. We don't want people that don't have it being treated, but we do want to make sure that people that do have it do get treated. And this is Rusty's challenge to get rid of the fail-first system. Many of our systems, because they're fee-for-service, are sometimes calibrated around, not today. And that calibration is a result of as much it's not just the fault of the delivery system, but it has to do with the incentives. If your incentives are different, and you do want to pay attention and find actually everyone that truly has it, and if you don't treat it, are going to end up in the hospital, and your hospital payment's going to come out of the same pot of money for each beneficiary, your incentives start to change, because now you actually want to find the people that really have it. And that's a population-based approach. And the theory is that capitation promotes that population-based focus, because you've got these enrolled beneficiaries, and your job now becomes not just treating the ones that show, but going to find the ones that truly have it, get them in treatment, and try to prevent progressive deterioration, because now you lose money if they get worse, as opposed to make money on procedures for that same population. The other thing you want to really avoid is planned versus unplanned service delivery. So just take an example of a child with asthma. The last thing you want is to be paying emergency room for asthma visits when you're capitated. What you want is that child showing up for their regular and ongoing planned appointments, because it's to your benefit, sadly, on the financial side, to maximize planned service utilization versus unplanned service utilization. You want to reduce activity that you're not able to manage and reimburse. And then the other thing that you want to start doing is defining what you want as results, including cost, for risk-adjusted cohorts. In other words, let's say people that have cardiopulmonary disease, you want to find them, you want to make sure they have it, that they truly have it. You want them to use services in a planned way, and you want certain results to occur that don't show increased costs but show reduced costs associated with managing that program. And so the theory is that payment systems can be designed and implemented that incentivize providers to address these goals. You can shift the incentives, and we're going to be talking about a little bit about what those are. What can be kind of guaranteed is that each payment system will include a mechanism for the payer to address cost containments for the services delivered, though. So the reason the federal government audits the heck out of you, or their agent, the state, in a fee-for-service structure is they are going to make sure that you are doing what you say you're going to do in terms of coverage, and they're coming in, they're reading all your charts and saying, well, this chart doesn't say that you did that. And they're taking back their federal money after the fact, because in a fee-for-service structure, that's how they do what they do. They go back in and see if you're doing the right thing. So they're accomplishing the goals up above, but they're just accomplishing them retrospectively because you're being reimbursed for volume. There are other payment systems that remove and change that environment, and those are the risk-based payment structures. But what I would say, and you two have said it well, is risk-based payment structures require significant changes in what you pay attention to and how you approach beneficiaries and providers. And the example I often use is, when you ask, nobody raised their hand, but how many folks pay attention to productivity? Oh yeah, we measure productivity. Why do you measure productivity? Does it have anything to do with patient improvement? No. What does it have to do with? Volume. You're measuring volume. And so productivity is the classic measure in a fee-for-service structure that most people pay attention to. Capitated payment structures can change that.
So I'm sorry, I'm probably not getting this, but we're already, well, from my perspective, we're putting people into hospital beds that are not reimbursable, and we're putting people in IMDs that's not reimbursable. So we're already getting drained of a lot of those responsibilities without ever being able to get the fee for service. How does the capitated system change that?
Interesting question, and actually the federal government just threw us a little, I won't say it's a curve. So there are some managed care regs the feds just put out, and actually in one of the regs, what they said is if you are in a risk-based structure, we're going to allow you to reimburse IMD days subject to certain provisions. We've also seen this happen in a couple waivers, and it's a significant issue because essentially what the feds are saying is if we're not at risk anymore for the hospital days, and we're just at risk for a capitated payment, and you're at risk for the hospital days, why does the IMD exclusion matter to us? Again, the federal government up here. So we see this chink in the door, but only in risk-based payment structures. No, risk-based, capitation. Yes. So it's kind of a reinforcement of this concept that the feds are starting to understand their risk differently. They're starting to being willing to, absorb and change some of the culture there, timeless culture at the federal level as the risk-based structures that they're paying folks for change. Now those are those regs that are in public comment, but we are aware of a few plans, capitated plans in other states under provisions of 1115 demonstrations where the feds have kind of looked the other way. There's actually something they call that, and Molly always remembers what it is, and I can never remember it because she's so much younger than me. But there is a word for it that they say, well, we'll just consider these, and we won't pay attention. So it's actually an example. Yeah.
Done.
Yeah. Am I done?
No, but keep going
Faster.
faster.
Faster. All right. All right. So payment perspectives. We're having our conversation as we go. So here they are. We beat fee-for-service to death. Prospective payments are actually payments. There are examples of this already. For example, Medicare and acute psych today pays a diagnostically based prospective payment. Certain number of days, they'll give you this much. As soon as you exceed those days, they start to reduce the payments. Eventually, the payments go down to zero. So they actually pay per admission as opposed to per day, and they adjust that payment based on certain variables, for the most part related to diagnosis. So we see this already. Also, the new community behavioral health initiative that's coming from the feds that California's applied for has a structure for building a prospective payment structure. FQHCs are also, for the most part, reimbursed on a prospective structure basis. And usually prospective payments can be limited, can be adjusted for various things. One of the things that we do see is using diagnostically based prospective payments is one example. There are other risk adjustments that can be made related to disability and things like that. But they're payments that are made in advance and theoretically are designed to incentivize a different kind of behavior other than a volume focus on the part of the provider. Case rates, which we heard a lot about today from Ron. Case rates are prepaid reimbursements to providers for each enrolled and served. So the key here, difference between a case rate and capitation, is case rates are actually payments for you to take the risk for a population and then actually serve that population, as opposed to capitation, which is a little bit different structure. Case rates could be a very good way to reimburse rehabilitative and other kinds of services because it does allow you to structure case rates around an identified population for an identified purpose. They have been used, for example, in home and community-based waivers, as Ron mentioned today, and what are now options under state plans. And then capitation rates are prepaid payments based on covered beneficiary enrollment, so a certain amount per member per month. They're enrolled or they select to be enrolled in a health plan. That health plan receives those payments in advance based on that enrollment on a monthly basis. And then the MLR that we talked about, medical loss ratio, you've got to spend a certain amount of that money on patient care, apply. Yes?
Are these variations of payment plans or methods taking into consideration individual needs? So that if you, like capitation.
Very good point.
And I'm thinking of where some of those options sound great and where some of those options might not be so great for different levels of need.
Yeah, no, and it's a very good point. So one of the things that you do see, for example, both in case rate and in capitation, is sometimes risk adjustments for certain populations. So one population, it's kind of a bad way to have to put it, but one population that is typically risk adjusted is the disabled population. They might be worth, again, bad way to put it, more per month, per member per month, or more per case rate than a population that is non-disabled. And the way that actually happens is through what they call Medi-Cal eligibility groups. So for purposes of eligibility, folks are kind of grouped into different categories, and then that category drives why they're eligible for Medicaid. And then the state then does track expenditures for those groups. So disabled, foster care, I think there's some pregnancy and other kinds of codes that folks are focused on.
I also think, I don't know what you're working about, because there's another way of looking at this. I mean, to probably say it the wrong way, you can have a schizophrenic who still has a job and is, you know, work in the community and stuff, but he has schizophrenia, or you could have a guy with a shopping cart living on the corner. And I think the needs of the guy in the shopping cart living on the corner are more expensive than the needs of the guy with a job and in the community. That's not stated very gracefully, did you understand?
It's okay. But Roy uncovers an important issue going forward that I think is going to be a real challenge in terms of this. So one of the policy issues that I think we face in mental health is we have traditionally driven the mental health population to disability for eligibility for Medicaid.
Yeah.
Today, we are driving them from potentially, if they're single childless adults, not currently disabled, but they do have early onset, we're driving them from 100% federal reimbursement to 50. So and again, I apologize again in advance that, sometimes this is not it's not an art, but these are the kinds of things that I think we really have to ask ourselves today from an incentives perspective. Do we have opportunities when the incentives all line up right? I would say that potentially, if we were financed correctly, to really go out and find early onset folks with schizophrenia, and we could keep them 100%, we create a win-win for ourselves. We have MHSA and everything that says employment, housing, don't drive people to disability. So sometimes all the incentives kind of line up maybe to do things differently, do the right thing, and support, as we've been challenged, a system that moves from fail first because we're just getting paid to do some stuff to find it early, treat it early, and maybe even sustain federal revenue, to the extent they remain 100% eligible.
Don, you may be getting this at some later slide, but what's important?
Probably not, because I only have 3 more minutes now.
What important, we're a group of people who want to provide.
Yes, you are.
As to which we like the best. Who are the decision makers? Who's the person? Who do I go to? Who do I email to say, pay us this way instead of that way?
It's a very good question, Ron. I'm very glad we have health plan folks here. So theoretically today, that is the challenge. So if we all get this and we all want to go that way, the health plans are already there. They've got these enrolled beneficiaries. They want to share and work with us. And I realize that, various perspectives on that. But at least from a financial perspective and enrollment perspective, we on the mental health side or behavioral health side are starting to realize that we may need to look at the incentives associated with our system. That doesn't mean we blow it up or get rid of it. It means we might want to look at that. But I think the challenge really is today, the ACA says it's time, and how that happens. And,
For Medi-Cal, are you saying, is it somebody in the Department of Health Services who's going to
no, I think ultimately, I think in this case, because of the structure of realignment, the counties and the state are going to have to come to an agreement first on the behavioral health side. I think the purpose of the 1115 drug Medi-Cal waiver is to build some infrastructure because they're behind, if you will. They need to build some infrastructure because their treatment infrastructure is smaller. But on the mental health side, we may be getting pretty close. Yeah.
Don, that's what that project you're doing with Mike guys around looking at the different rate structures. You picked out several counties to try to compare.
Your
Is that
county.
What you're looking at is case rate versus capitation?
What we are looking at is this whole paradigm is where do we want the delivery, where is the delivery system today? Where do we want it to be? And then what payment structure would support that?
Would support that.
Yeah.
You might conclude that case rate would be better than capitation.
You could. I mean, just to be crass, capitation works great when beneficiary enrollment's doing this. Capitation sucks when, you know, so.
Versus a strong disabled population, an ill population, case rate might make more sense because it's more long range.
Case rate probably works better if you can define your population more specifically and what you're going to cover. So in certain circumstances, a case rate for a defined population, say those with disabilities, it may work better. So there are ways, just very quickly, because we beat the fee-for-service system up to death here, and that's not always a good thing to do. There are ways to create incentives in fee-for-service to improve care consistent with the goals of the payer. And I do know health plans are very interested and are doing that. So there are pay-for-performance goals. So in other words, you pay the provider this much, and you give them the rest when they hit certain performance goals related to, say, treatment for diabetes, that they're able to show that they're following protocols for treatment for diabetes, and they show some population-based improvements. It is possible to structure fee-for-service payments so they do support performance. So they're not evil inherently, they just need some adjustment. I think the rest of those are fairly... So this was the discussion part that we already had. But let's just go to the bottom. Does anyone in the room think that it is not a good idea? Now, we're not talking about blowing up the carve-out, but is there anybody in the room, and this is just a little poll for in here, you all come from different places, that a transition from non-risk to an at-risk federal payment structure might be necessary? Doesn't mean it's going to happen tomorrow, but...
Do we think it's necessary? Yes.
Yeah, I think I put it in a negative, didn't I?
Yeah.
I did. No. It's like, is that a double negative? So, yes, good. Dissension, maybe not.
Well, I'm not dissenting, I've just been like processing what you've been talking about the whole time. And it seems like we're moving toward, I was thinking like fee for service to me is thinking about someone, you're paying someone hourly, if they're working for you, you're paying for volume. Capitation, I almost think is more like salary, you're basically saying, I expect this level of work out of you, I'm gonna pay you this much related to your responsibilities, and then figure it out. But really what everybody's trying to get to is pay for outcomes, right, which is.
Good point. Pay performance.
X performance, and we'll pay you based on that performance. The issue right now is we don't have the data to really track, is everybody getting served? Are they getting better? Is everybody getting treated? And that's kind of where we're going long term, I hope. So at that point, it would be that the risk should be with whoever can most effectively handle the thing we're trying to handle. So for example, a provider shouldn't hold the risk for the population being served in a county, because it depends on who should hold the risk for. The county should perhaps
How it be shared.
That everybody's getting covered, et cetera, and then the provider should be at risk for certain things that they have control over, like is the person getting better when they're in that care?
And incentivized to do that. Yeah, I think
what is the risk for the federal government, and what do they have control over?
you've talked me into changing my slide. I think it needs to be, I think we need to acknowledge that really is ultimately the goal. You're correct. This is about performance. And what is it that we're paying attention to, not just the payment structure. Good point.
So
Good
the
point.
question is, fee for service the best way to get to performance outcome? I mean, in fact, that's your question.
I think actually he's kind of helping us reverse it, is what do we want to accomplish, and then we'll figure out
Right.
which payment structure works. Let's start with what is it that we want to accomplish. I think that's a very good point. And remember, it's just the 4 areas. How many people have it? How many get in? What are they getting when they get in? And what's happening to them based on that? Those are the areas we need to pay attention to. I'm sorry, go ahead.
I was going to say capitation or case rate on quality indicators built in.
They could be. They could be with the appropriate incentives. But I think the point is, again, as we have to make sure while we're having the conversation, we're also focused on what it is that we want and how are we going to measure it. I would say the measurement structure is more in place than we realize. All the information that health plans are doing based on every encounter to every patient, and all your short oil information is all going into a data warehouse at the state, somewhere up there. And it's all coded the same beneficiary, same MPIs, same diagnostic codes, and it's available to start data mining to see if Joe, patient 1, how many people have treated him, what's he been treated for, and what has happened. It's all there, and I'm just dying to know what's happened to Joe.
At the same time, if they track this data even deeper, can it be potentially in the future that the managed care plan or whoever's managing it can say, I know that Don is a great therapist because he's treated 18 bipolar clients who have a duration of treatment of this length versus Sally or Scott that treats the same population and it takes twice as long for them to get better. I mean, are they gonna be able to compare at that level?
It is what's happening in the hospitals already, yes. You see the beginnings of these report cards about hospital-based infection rates, readmissions. Mental health plans are soon to be measured based on readmissions within 30 and 60 days.
They're not really measuring outcomes, though. You're measuring the, not another incident.
It's really an important point, Marie. So this issue of is that an outcome or not? In healthcare, they differentiate between the social determinants, things that are there that impact health, and things that health can actually impact. And I think sometimes in the mental health field we're getting a little confused about the two. Bottom line is we can impact readmission. Other bottom line is there may be a bunch of social determinants that are happening that we can impact available to housing. They're impacting that readmission. But in the world of measurement, I think healthcare has been a little more strategic and focused and kept itself from taking on more responsibility than it actually can intervene to create. Yeah. Now that's not to say that if you do enough things right that they are paying attention to, that you won't actually have an ultimate impact on some of the social determinants.
Adverse activity.
Yes.
One more question.
You're about to get the vote.
Roy's going to make a statement.
Okay.
Go ahead. All right. Thank you very much, you guys. Thanks for the conversation.